The following podcast is part of a certified educational activity titled How I Think, How I Treat, Embarking on a New Treatment Era in Hepatocellular Carcinoma, a personal take on integrating recent evidence into the continuum of care for patients with HCC. Access the entire activity and complete the post-test at peerview.com/XEJ860. Downloadable slides and practice aids are also available.
Hello, good evening, everybody. Thanks for being here. My name is Ghassan Abu Alfa, and I'm honored to be part of a great panel with my colleagues. And we're going to tell you how we think and how we treat HCC, especially nowadays with all the advent of the new therapies. I'll be joined today, as you can see, I'll go from from your right to your left. So Dr. Amit Singhal, who is a hepatologist who really quite involved in the world of HCC as well as understanding the organ itself. Dr. Tim Meyer from University College of London, and Dr. Ruth Hay from Georgetown in Washington, both oncologist with a high interest and quite a bit of expertise and a lot of involvement in regard to the development of the drugs we're going to talk about. With this said, I'll start by really putting a little bit of a projection for you on where the disease stands. These numbers reflect only in the US. This is a very nice publication that I strongly recommend that you look at back from JCO in 2016 that looked at the incidence of HCC up to the year when it was evaluated, and with the projection afterwards. They collected it until about 2013, and then after that they did projections. As you can see, in a large scale, we can see that it's on the rise. Maybe we have some deflections or changing, and I think the one that really is quite impressive, the one that you can see in blue for the Asian population. And understandably, this is an important one because nowadays we vaccinate everybody for hepatitis B, which is the risk factor among the Asian immigrants in the US. As we know, it's not anymore dependent only on first-generation immigrant, but rather we have people who are born here and they are actually part of the community and they are living in the US. And as such, like everybody else, they are getting vaccination when they are born. And so big accolade for this, the reduction in the incidence of HCC among the Asian population in the US. On the other hand, you can see that for the Hispanic and Black population, there's a mild curve, but it's a little bit shy of getting into a decline that was projected for 2030. And the reason is that, sadly, despite that we have the curative treatment for hepatitis C nowadays, as we can imagine, we are not necessarily having 100% access of the drugs for everybody. And as such, as we can imagine, even with few patients with hepatitis C pooling around in the community, that's enough to really keep the presence of the virus as a risk factor for HCC. Where this will take us, we're not sure. And I would say probably this kind of mild trend, but though it's not clear, is a little bit of a wishy-washy perspective that we just have to wait and see what's going to take us from there. So then you wonder how come with all those good news about Hep B with the vaccination and Hep C with the treatment, why we have this continued rise? Sadly, the problem is that we have still a continued persistence of alcohol as a risk factor, even though it's not changing, it's not increasing, but sadly it's not declining. But the other one, which is most important, which is really driving this continued rise in the curves, is actually the non-alcoholic fatty liver disease that leads to non-alcoholic steatohepatitis and lead to HCC. And this nice work that was first reported by Dr. Kali, you might remember this was a very well recognized article back in 2003 in the New England, where Dr. Kali with her colleagues tried to figure out, based on body mass index, what is the risk of dying from a cancer. So simply looking at the body mass index and see what the correlation as an independent factor for dying from cancer. And as we can imagine, the body mass index in general in the population range between 19 to 25. Whenever the body mass index, as we can see here, is more than 35, there is a certain increased rate of the risk for cancer. If you look at the bottom compared to the prostate, which is 1.34, for liver cancer, it's close to 5%, i.e., patients who have a body mass index more than 35, they have, independent of anything else, a 5% risk of dying from liver cancer. And unfortunately, because morbid obesity and add to it diabetes are on the rise in our country, that's really the problem why we're going to continue to see a rise in HCC. Now, another important component that I would like to make sure that we put in perspective is that liver cancer is two problems in one. You have the cancer itself, but you have the liver functionality. It's not necessarily critical that always there will be some component of cirrhosis, but most of the time there will be. As you can see, Child-Pugh scoring consists of 5 parameters: albumin, bilirubin, PT-INR, which usually you can measure those 3, and you get a value from the lab. In addition to that, there are 2 subjective assessments, the ascites and the encephalopathy. And based on severity, you get 1 or 2 or 3 points, and patients will end up with its score being A, B, or C. Now, very important components here, and these are critical, is the sequence of the albumin, bilirubin, PT-INR, etc. is not haphazard. Actually, it happened in a certain sequence, exactly as you have it delineated over here. Albumin, bilirubin, ascites, encephalopathy, PT-INR. So this is really how the liver would, unfortunately, continue to worsen. Number 2 important component is that it's one-way street. It's not really that you can move from A to B, then to C, then you can go back to A. No, unfortunately, once the damage happens, most likely patients will continue in the same trend. In addition to that, this is not a linear curve. It's not like patients move from A to B to C at the same rate. If anything, A is really a long line. It starts and never ends, enough that patients will even forget they have anything Child-Pugh A or about cirrhosis. But then B is a little bit of a curve, and C, unfortunately, is huge. And it's very important for us to try to catch patients early while Child-Pugh A, and of course, try to keep them in the Child-Pugh A as much as possible. With this said, another staging system, which I have to admit I'm not a big fan of, but nonetheless, as an oncologist, we don't necessarily use it much, but nonetheless, it's really kind of a good delineation for what we do. It's called the Barcelona Clinic Liver Cancer Staging. Why I'm showing it here? Because interestingly, the way the BCLC was done, and give credit for Dr. Bruges and his colleagues who built this, is that it has in it a manual. What do you do? It's like you open a catalog and say, you do this, you get that. And if anything, for small disease, good liver, get it out, cut it. Small disease, bad liver, transplant. Advanced disease, locally, local therapy. And then understandably, everything else will go into systemic therapy. And this is what we're going to talk about. As you can see over here, a couple of caveats. Number 1, it delineated only Sorafenib at that time because this is what was available at that point in time. Number 2, if patients are in one category, they stay in that category, which is not the case. And it doesn't talk about how patients move from one category to the other, or within the one category, how they move from first to second line, etc. So we'll see some nuances of this staging system as we move on in the discussions. So with this introduction, number 1 is Dr. Singhal will give us the evidence supporting the multiple tyrosine kinase inhibitors and targeted options for HCC management. Dr. Meyer will give us the latest data on immunotherapy, checkpoint inhibitors options in advanced HCC, including the combination strategy that could apply from that. Dr. Hay will be talking to us about the future directions with novel agents from their use in special populations and to TKI immunotherapy combinations and beyond. And will share our personal insights and clinical experience and how the novel therapeutics have influenced our own practice as well. So with this said, I'm again greatly honored to introduce Professor Singhal on enhancing the treatment paradigm with targeted therapy for advanced HCC. Amit, please.
Thank you, Ghassan. So honored to be here, and as Dr. Abu Alfa said, I'll be talking about TKIs and the current therapies that we have for advanced HCC. So to start, I'm going to just show a figure that's an adapted version of the BCLC. This is similar to the figure that Dr. Abu-Alfa just showed you. And really what I want to highlight is that systemic therapy, the main focus, what we're going to be talking about today, fits into our larger treatment landscape. And so as you already heard, if you find this at an early stage, we have curative therapies available, including liver transplantation, surgical resection, and ablation. And as you can see here, that's really where you afford the best survival. So survival extends beyond 5 years. And so while I agree that there's been significant advances in systemic therapy, I think that it's also important for us to make sure that we consider the larger landscape, and if you find somebody with early stage disease, to refer on to these curative therapies if and when possible. As you'll hear about tonight, it's really an exciting time. We've seen an expansion of systemic treatment options. You saw the slide that Dr. Abu-Alfa just showed you, that actually we used to have Sorafenib built into the guidelines because that was really the only systemic therapy we had. And as you can see here, we now have 5 TKI agents that have actually been approved in terms of the therapy for HCC. We have 2 first-line therapies and we have 3 second-line therapies. In addition to these therapies that are supported by phase 3 data, as you'll hear in the second half of the program, we also have immunotherapy agents that are supported by phase 2 data. With this expansion of systemic therapy, I think that, as you heard, we're starting to see that the BCLC is starting to potentially break down a little bit. And what you're finding is that as systemic therapy improves and as survival improves, there's more and more questions if some of these patients who have BCLC-B disease, particularly those with large, bulky tumors in whom the chemoembolization trials actually never enrolled, maybe some of these patients should also be considered for systemic therapy. And so I think that these solid lines that were built up between BCLC-B and BCLC-C are now starting to become dotted or gray, and we're starting to see a blurring of these barriers. So when we take a look at our frontline treatment options, we can see that we now have 2 treatment options that are supported by high levels of evidence and have a strong recommendation. Both Sorafenib and Lenvatinib, in terms of most recent guidelines, have a strong recommendation in terms of consideration for first-line therapy. So over the next few slides, I want to go through the data that actually supports these recommendations. So this is a slide that I think many of you have seen several times. This is the data from the SHARP trial that now have been released from over the last decade. So this was published in 2008. This took 600 patients that were randomized to either Sorafenib, 400 milligrams twice a day, or placebo, and as many of you have heard several times, this resulted in a significant prolongation of overall survival. Median survival of 10.7 months for the Sorafenib group versus 7.9 months for the placebo group, with a hazard ratio of 0.69. As many of you recall, these are patients who have Child-Pugh A disease, so good liver function, good performance status, but have advanced tumor stage, so often have macroscopic vascular invasion and or extrahepatic spread. Now, Sorafenib, as you know, has been the therapy that we've had longest on market. So the nice thing is that we don't just have registration data, but we also have real-world effectiveness data. And so the Gideon study is one of these post-marketing studies that shows how well Sorafenib does in the real world. So data from Gideon not only show that when you apply this to Child-Pugh A patients in real-world practice, that survival that you saw in the SHARP trial actually translates into actual practice, but Gideon also evaluated tolerability in Child-Pugh A as well as Child-Pugh B patients, so patients that were not included in the SHARP trial. And I think the big thing that you can take away from the slide is that Sorafenib safety results are really consistent across both Child-Pugh A and Child-Pugh B patients. So we don't see increased safety concerns in these patients who have more advanced liver dysfunction. Now, I remember when the SHARP trial came out, we all sat around saying this is good, but we're going to have much better therapies in just a year or two. We finally have figured out HCC. And all we had over the next 10 years was negative trial after negative trial, and there started to be more and more pessimism that maybe Sorafenib was all we would ever have. But the nice thing is that over the last couple years, we've actually now had several positive trials. So as I said, starting off this talk, we've now gone from 1 agent to 5 agents that have been supported by phase 3 data, and as well as the immunotherapy that is supported by phase 2 data. So I think the pessimism is starting to fade, and we're starting to see more and more agents come to market. So before we get into the positive data, I think that it's worth pointing out some of the reasons why we had so much negative data over the last 10 years. I think the first thing is that we really have a limited understanding of molecular drivers of HCC. So as many of you recall, HCC diagnosis is often made non-invasively. So in the setting of cirrhosis, we can make an HCC diagnosis with high positive predictive value just in the presence of arterial enhancement and delayed washout. And so compared to many other cancers, we often don't biopsy these patients. So this is great if you're a patient. You don't have to undergo an invasive procedure, but I think it really set the field back in terms of our understanding of HCC, including molecular drivers, and really some of the therapies that were proposed were a little bit of a stab in the dark. The second is what you heard from Dr. Abu-Alfa already. This is a complicated disease. It's not just cancer. You have cancer and you have cirrhosis. So it's two diseases where you have to balance efficacy of the drug to treat the cancer, as well as concerns about toxicity in the setting of advanced liver disease. And then the third thing is moving on to phase 3 data or phase 3 trials without clear signals. It's still a little bit unclear what the best surrogate endpoint of survival that should be used in phase 2 data. In terms of time to progression, we've seen actually contradictory data, whether this actually translates into overall survival benefits, and even objective response rates, you can argue, are an imperfect signal. So when you take a look at many of the TKI agents, including Sorafenib, you don't necessarily see high rates of objective response, but it still translates into a survival benefit. And so there's not a clear signal that you can look at sometimes in these phase 2 trials to move on to phase 3 trials. So now going on to the other first-line therapy that we have, Lenvatinib. So Lenvatinib, as you know, is a multi-kinase inhibitor that acts on multiple receptors, including FGFR, VEGF, c-KIT, and then PDGFR. In terms of the REFLECT phase 3 trial, once again, this is patients who have good liver function, so Child-Pugh A, good performance status, but have advanced HCC. One of the other things that's worth noting about the inclusion-exclusion criteria is that the REFLECT trial excluded patients who had greater than 50% liver involvement, bile duct invasion, or invasion of the main portal vein. You can see the stratification listed there. Patients were randomized to receive Lenvatinib at its weight-based dosing, 8 milligrams if you're less than 60 kilograms, 12 milligrams if you're above, or randomized to Sorafenib at its standard dose of 400 milligrams twice per day. The other thing that's worth noting here in terms of trial design is that this was a non-inferiority study design. And so you can see here, compared to many of the other studies that we'll talk about, the actual number of patients that were included is much, much larger to give it power in terms of being a non-inferiority study. Here you can see the demographics of the patients that were included in the trial. The age and gender is what you would expect. About 2/3 of the patients were enrolled in the Asia-Pacific region, and because of that, you see that in terms of hepatitis B, this accounted for just about half of patients. Once again, as we talked about, patients had good liver function, good performance status, but the majority of the patients, just about 70%, had either vascular invasion or extrahepatic spread. The other thing that's worth noting, as we see a change in terms of how we interpret things, it's worth noting that over 40% of patients had an AFP greater than 200, with a higher median baseline AFP in the Lenvatinib group compared to the Sorafenib group. So in terms of the primary outcome, you can see here that Lenvatinib had non-inferior overall survival compared to Sorafenib, with a median survival of 13.6 months versus 12.3 months for Sorafenib. The hazard ratio was 0.92. The 95% confidence interval does cross 1, so it does not reach superiority, but it's well within the non-inferiority margin, so we can say with comfort that Lenvatinib has non-inferior overall survival compared to Sorafenib. When you take a look at subgroup analyses, it's nice to know that this is actually consistent across all examined subgroups. I think the one that I'd like to point out here is actually, we do know that there are data for Sorafenib that it works better in specific subgroups. For example, I think one of the most notable ones is that Sorafenib is noted to work better in hepatitis C populations. But when you take a look at the REFLECT trial population, even in that subgroup, Lenvatinib had non-inferior survival compared to Sorafenib. So at least in my opinion, I don't think etiology can be a good factor in terms of differentiating between Lenvatinib and Sorafenib use. So because it reached its primary outcome, we look at several secondary outcomes that were pre-specified. I show here one of them, objective response rates. And whether you look at mRECIST or RECIST 1.1, lenvatinib had just approximately 3 times higher response rates compared to sorafenib. Taking a look at mRECIST, you see response rates that are approximately 40%, and by RECIST 1.1, you can see response rates just around 18 to 19%. When you take a look at both lenvatinib and sorafenib, the vast majority of responses are partial responses. Very few complete responses in both groups. This is an interesting post-hoc analysis that was recently presented. This is a pooled analysis taking a look at responders in both the sorafenib and the lenvatinib arm and comparing patients who have response versus non-response. As many of you know, we've known for a long time that response matters with local regional therapy, but it's been a debate in terms of systemic therapy. So we've gone back and forth whether response matters. But I think this is a nice analysis that shows response does matter. So response in this post-hoc analysis was associated with significantly better overall survival, 22.4 months versus 11.4 months with a hazard ratio of 0.61. When you take a look at the AE profile between sorafenib and lenvatinib, the incidence of AEs overall, and when you take a look at grade 3, grade 4 AEs, is no different between the two groups. So the two groups overall have a similar AE incidence. However, the specific AEs that you see dramatically differ between the two groups. And so when you take a look at this, hand-foot skin reaction is significantly more common with sorafenib than lenvatinib. In contrast, other AEs like hypertension, anorexia, and proteinuria are more common with lenvatinib. And I think that this is one of the things that I use in my practice to actually choose between the two therapies. So this is a summary in terms of first-line therapy and some of the things that we can take a look at and help select between the two therapies. Both of these therapies are supported by phase 3 data. I highlight the differences mainly in red, or at least the differences that I think are important. So in terms of inclusion-exclusion criteria, you saw that the REFLECT trial did exclude patients who had greater than 50% involvement, main portal vein invasion, and or bile duct invasion. It doesn't necessarily mean that lenvatinib doesn't work in those patients. We just don't have data in those patients at this time. I expect those data to come out as this is used more and more in real-world practice. In terms of efficacy, the two have similar survival, but we know that lenvatinib has improved objective response rates compared to sorafenib. Once again, the AE profile I just talked about, but does differ between the two agents. Both of them are oral. There is difference in terms of taking it with or without food. And then, once again, the other thing is that sorafenib does have real-world effectiveness data because it's been around for the past decade, so we know that this does work in some expanded populations. So if I were to give this talk even just a couple years ago, this would be it. We would just have first-line therapy. We didn't have any second-line therapies. Once again, an exciting time because now we actually have therapies if patients are either intolerant or progress on first-line therapy. So when we take a look at recommendations, we now have 3 agents that are supported by phase 3 data, have high levels of evidence and strong recommendations. So Regorafenib, Cabozantinib, and Ramucirumab. And then once again, we have a couple agents that have moderate evidence and weaker recommendations, which you'll hear about later tonight. So in terms of the RESORCE trial, this is the trial that actually led to the approval for Regorafenib. This took patients who that were on sorafenib, tolerated sorafenib, so had to tolerate sorafenib for 20 of the last 28 days at a dose of at least 400 milligrams a day, but had documented radiographic progression. Patients were randomized 2-to-1 to receive regorafenib at its dose of 160 milligrams orally, 3 weeks on with a 1-week holiday, or placebo. And here you can see the overall results. So the median overall survival, 10.6 months versus 7.8 months, with a hazard ratio of 0.63. The curves separate early and stay separated over the course of the trial. Once again, when you take a look at subgroup analyses, overall, regorafenib had a benefit in all subgroups that were examined in the trial, and so the benefit appears consistent across all examined subgroups. When you take a look at responses, there are response rates that are higher with regorafenib, 10% versus 4% compared to placebo. Once again, a very low rate of complete response with regorafenib. The vast majority of patients in the regorafenib arm, 54%, had stable disease compared to 32% in the placebo group. When you take a look at the treatment-related AE profile, this is very similar to what we saw with other TKIs, specifically with Sorafenib. Once again, you see hand-foot skin reaction, diarrhea, fatigue, hypertension, anorexia. Once again, the AEs that we're used to seeing and used to managing in our patients that have been treated with TKIs in the past. This is a nice post-hoc analysis that was done looking at the patients who were randomized in the RESORCE trial. So this actually examined survival starting at the time of Sorafenib initiation, examining it through the RESORCE trial. So examining it through being on Regorafenib and or placebo. And what you can see here is that when you actually sequence these therapies, so if patients are able to actually maintain good liver function, good performance status, go on to receive second-line therapy, you can actually achieve very meaningful survivals with a median survival of 26 months with patients who receive these 2 lines of therapy. I actually find these data to be very helpful when I talk to my patients, because I think that in the past we used to have a little bit of pessimism saying, oh, even if I go on first-line therapy, I still have an average survival right around a year. But here we can see that using these agents in a sequential manner, we can actually have very meaningful survival, approaching, if not exceeding, 2 years. Going on to the Celestial trial, so the Celestial trial led to the approval of Cabozantinib. Cabozantinib, once again, is a multi-kinase inhibitor. I think the thing that's worth noting here is that Cabozantinib does hit a couple other pathways, the c-Met pathway and the AXL pathway, which are pathways that can be used in terms of tumors being resistant to VEGFR TKIs, as well as potentially giving a little bit more immunologic effect with Cabozantinib than some of the other TKI agents. So the Celestial trial took patients who had, once again, good liver function, good performance status, and then prior Sorafenib therapy and advanced HCC. I think the thing that's worth noting in terms of the Celestial trial, one of the things that's unique about this is that patients were required to receive prior Sorafenib, but 27% of patients had actually received 2 prior systemic therapies. So I think the Celestial trial gives us not only data for Cabozantinib in the second-line setting, but also arguably in the third-line setting as well. So patients here were randomized 2-to-1 to receive Cabozantinib at a dose of 60 milligrams a day, or placebo with a primary endpoint of overall survival. In terms of the main results, you can see Cabozantinib produced a median overall survival of 10.2 months versus 8 months for placebo with a hazard ratio of 0.76. Once again, the curves separate early and stay separated over the course of the trial. In addition, you see significant prolongation and improvement in progression-free survival. Median progression-free survival, 5.2 months versus 1.9 months, with a hazard ratio of 0.44. When you take a look at subgroups, once again, Cabozantinib had a survival benefit across all subgroup analyses. The one that I'd like to point out here is the prior lines of therapy. You can see here that Cabozantinib did have a benefit in terms of in terms of second-line and third-line therapy, but if you take a look, it does look like, at least numerically, the benefit of Cabozantinib is better or more in the second-line setting than in the third-line setting. Of course, this isn't a formal moderator analysis in terms of seeing if this is significant, but there is potentially more benefit if you use this in the second-line than the third-line setting. Once again, nothing surprising in terms of the AEs you see: hand-foot skin reaction, hypertension, elevated AST, fatigue, diarrhea, asthenia, and decreased appetite. I think the thing that is worth noting is that many of the patients on the Celestial trial did require dose reduction, and the median dose that patients were on was closer to that 40 milligrams, but all patients were started at that recommended dose of 60 milligrams. When we take a look at this, I don't think that we should be too afraid of AEs. There are now more and more data showing that there's a correlation between patients who have AEs and efficacy. The first data we saw, obviously, with Sorafenib, and there's been several studies that have shown patients who have hand-foot skin reaction after Sorafenib initiation actually have better survival. So the drug appears to work better in these patients, including studies with formal moderator analyses. Once again, same thing was true of Regorafenib. This was a post-hoc analysis that was done as part of the RESORCE trial. Once again, those patients who had hand-foot skin reaction at any time had better overall survival. And there is a poster presented here at ASCO, which shows the same thing to be true with Cabozantinib. Those patients who have hand-foot skin reaction or hypertension have better survival than those patients without. So I think these are important points to keep in mind, as well as inform your patients. Obviously, if somebody has AEs, it's important to manage them, treat them, dose reduce as needed. But I don't think that this is a reason to abandon these therapies. It actually may suggest that these patients are more likely to benefit and to appropriately manage and try to get these patients through the AEs. Finally, the most recent therapy that's been approved in terms of second-line therapy. So this is the REACH2 trial, which led to the approval just recently of Ramucirumab. So the story for Ramucirumab, as many of you know, Ramucirumab was originally evaluated in the REACH trial. The REACH trial took all comers in terms of evaluating this in a second-line setting. But unfortunately, the REACH trial was negative, failed to show a benefit of Ramucirumab, as you can see there, with a p-value that did not reach statistical significance. But when you take a look at this, and you take a look at the subgroup of the patients who had a high AFP, so an AFP that was greater than 400 nanograms per milliliter, Ramucirumab appeared to be of benefit in that subgroup. And that's the Kaplan-Meier curve that you can see here. And you can see the results in that subgroup with a hazard ratio of 0.67. So the nice thing is that a full-on phase 3 trial actually conducted in this subgroup of patients. And so took patients who had AFP greater than 400, and then once again randomized them to receive Ramucirumab or placebo. And once again, the REACH2 trial confirmed what we saw in the subgroup analysis from the REACH trial. So you can see that Ramucirumab did have a significant benefit with a median overall survival of 8.5 months versus 7.3 with a hazard ratio of 0.71, p-value of 0.02. And so this is basically a pooled analysis of the two, where you can basically see that once again, Ramucirumab, when you take a look at this, appears to have a benefit in those patients with an elevated AFP. And then there is a poster presented here at ASCO that stratifies this by Sorafenib intolerant versus Sorafenib progressors. And so you can see that Ramucirumab, in terms of the benefit in each of those two subgroups. In terms of the AEs for Ramucirumab overall appears to be very well tolerated. When you take a look at the grade 3 reactions, I think the two that are worth noting out here is hypertension. So you can see a significantly higher proportion of patients had hypertension with Ramucirumab than placebo. And then once again, there was a signal in terms of hepatic encephalopathy, grade 3 being observed in just about 3% of patients on Ramucirumab versus no patients in the placebo group. So similarly, in terms of summarizing the last few slides, you can see that all three of these agents are supported by phase 3 data. When you take a look at the red outline here in terms of the inclusion-exclusion criteria, it's important to remember for Regorafenib, patients had to have tolerated Sorafenib, but had radiographic progression. The way that this was operationalized for the trial was being on Sorafenib 400 milligrams a day for 20 of 28 days. I don't think we have to necessarily dig that deep when we're talking to our patients. So if patients were on it for 19 days, I don't think we should say like you can't be on it. But I think that there is some measure of having Sorafenib tolerance for being on Regorafenib. In terms of Cabozantinib, once again, the nice thing is that these patients could have received not just one line of prior therapy, but even 2 lines of prior therapy. And then Ramucirumab, I think it's important to remember that the REACH trial actually shows us that this does not work in patients with a low AFP, and this should be reserved for patients who have elevated AFP greater than 400. In terms of the efficacy, all of them improved overall survival. I would urge you not to do too much cross-trial comparison. I think the big thing is that these all showed improved survival compared to placebo in the second-line setting. In terms of AE profile, Regorafenib and Cabozantinib have a similar AE profile to other TKIs. And then Ramucirumab overall appears to be well-tolerated, low rates of dose reduction or discontinuations. Regorafenib, Cabozantinib, both given orally, and then Ramucirumab logistically is different. It requires an IV infusion, and so that may be a consideration talking to patients, particularly if they travel from further away. So putting this all together in terms of both first-line and second-line data, the nice thing is that we've really extended beyond, the slide that Dr. Abu-Alfa showed you in terms of where we were just even 3 years ago. We now have 2 agents in the first-line setting, Sorafenib and Lenvatinib, that both improve survival, and then we have 3 agents that have phase 3 data, once again, Regorafenib, Cabozantinib, Ramucirumab, and then the 2 other agents, Nivolumab and Pembrolizumab, that you'll hear during the next couple talks. So I'd like to just put this together in terms of how I think, how I treat, trying to put this together in terms of a couple cases. So in terms of a case, I want to go through a case of a 57-year-old male who has NASH cirrhosis. He has, along with NASH cirrhosis, as you've heard from Dr. Abu-Alfa, this is associated with the metabolic syndrome. So he has obesity, he has diabetes. Because of the diabetes, he has stage 2 nephropathy, and he has poorly controlled hypertension. In terms of liver function, he has good liver function. He's Child-Pugh A. He has no ascites, no encephalopathy. He has an AFP that's just mildly elevated, but less than 400 nanograms per milliliter, and he has a good ECOG performance status. So when you take a look at his MRI, he actually has multifocal HCC. He has 4 lesions, largest 6 centimeters. No evidence of vascular invasion or distant metastatic spread. I think all of us can agree that if this patient, does currently fall into the BCLC-B algorithm and would, in most centers, be treated with local regional therapy. So in our center, we actually treated him with radioembolization, and then he had stable disease on follow-up. He had chemoembolization at that time, but unfortunately was then noted to have disease progression, including new tumor thrombus involving the main portal vein. So in terms of first-line therapy options, we have 2 first-line therapy options, Sorafenib and Lenvatinib. In terms of the way that I would choose therapies in this patient, I would actually personally put this patient on Sorafenib. I think the thing that you would see in this patient is that he does have nephropathy, and he does have poorly controlled hypertension. And as we talked about, the AE profile between the 2 drugs does differ. So we see proteinuria that can happen with Lenvatinib, as well as an exacerbation of hypertension. Not to mention, we did talk about the inclusion-exclusion criteria, and you can argue that there is less data for Lenvatinib in patients with main portal vein invasion at this time. So this patient was started on Sorafenib at a dose of 400 milligrams a day. We actually start at a reduced dose of 400 milligrams a day at our center. We put this on for 2 weeks, and then we dose escalate to 400 milligrams twice daily, assuming patients tolerate it. At 2 months, he developed some hand-foot skin reaction. This was held, and then once again, we started at a lower dose, had stable disease, but then was noted to have new metastatic disease at 9 months. Once again, he has good liver function. His AFP is increased to 1,000, continues to have good performance status. So what would be appropriate treatment options for second-line therapy in this patient? Here you can see the choices. And I think the big thing is that all of these would be choices. We can use any of these. The only thing that's wrong is to actually put this patient on best supportive care. I think this is important to remember, that we do have second-line therapies, and it's important to refer these patients on. So if we change this up a little bit and say that he actually had significant hand-foot skin reaction and actually hadn't tolerated Sorafenib, then what would we say would be potential treatment options? And if he was intolerant to Sorafenib, this would actually make it so Regorafenib would not be a good treatment option. Once again, modifying the case a little bit, let's say that he hadn't tolerated Sorafenib and he had a low AFP. This would also take out Ramucirumab, and really the one that would be left in terms of treatment options in this case would be Cabozantinib.
It's a great, great honor and pleasure to welcome Professor Meyer to the US and to our program here with PFU for talking about how I have adapted my practice to immunotherapy revolution in HCC. We are very eager to hear that, especially now we have a voice from across the ocean to see really what does that mean. So Tim, please tell us all about checkpoint inhibitors.
Great, okay, thanks very much. So I'd like to thank Gaston for the kind invitation to talk tonight, and for the organisers, and to all of you for coming. So I think the scene was very nicely set in terms of advances in TKIs. Lagging slightly behind that have been advances in immunotherapy, and currently we still don't have any phase 3 data, but I'll take you through the data that we do have, and you can make a judgment about where you think the future is. So first of all, in terms of the rationale for developing immunotherapy in liver cancer, we do have some clear evidence from surgical resection specimens that the immune system is important. Now, this was a study published way back in 2017, and already showed that if patients have high infiltrating T regulatory cells, so these are the cells which damp down the immune system, if these are high, then patients do poorly. On the other hand, patients that have high levels of cytotoxic cells, cytotoxic CD8 cells, so these are the killer cells, these patients do better. So this was sort of initial evidence that the immune microenvironment is important for controlling liver cancer. The further evidence in terms of expression of PD-L1, so PD-L1, as you know, is part of the immune regulatory axis. The expression of PD-L1 is thought to reduce or inhibit T cells, and therefore reduce the immune reaction against the tumors. And again, you see that patients that have a low level of PD-L1 in their tumors that are resected do better than those that have a high PD-L1 expression. So if we then move on to look at the potential approaches to immunotherapy in all cancers, including liver cancer, one can see, if we just focus on the right, that the T cells express a variety of different mechanisms to regulate their activity. So on the left-hand side, we have a range of different co-stimulatory molecules, and on the right, co-inhibitory molecules. And there are drugs now to target all of these. So on the one hand, you can put the accelerator on the immune system by activating the co-stimulatory molecules. On the other hand, one can block the activity of the cells by interfering with the co-inhibitory molecules. So the drugs are listed there. As you're very well aware, the main focus has been on targeting CTLA-4 and PD-1. And for liver cancer, the drugs which have been used to date targeting CTLA-4 include tremelimumab, ipilimumab, and for PD-1 inhibition, we've got nivolumab, pembrolizumab, durvalumab, atezolizumab, avelumab, camrelizumab, and tislelizumab. So where are we up to in terms of data for patients treated with immunotherapy? So we already have published data for nivolumab and pembrolizumab. These are FDA approved. We don't have approval in Europe because these haven't gone through randomized trials, but they are now available to patients in the US. And then in terms of what's emerging, the data is looking at combinations. So looking at nivolumab in the first-line setting, pembrolizumab also in combination with Lenvatinib, and then tislelizumab, another single-agent PD-1 inhibitor like nivolumab and pembrolizumab in the first-line setting. And then we have durvalumab and atezolizumab, both used in combination. So a huge amount of activity and drug development going on with immunotherapy in liver cancer. So if we start off looking at PD-1 inhibitors where we have good published data, the first trial was this Checkmate 040 study. And as you can see, this is a multi-cohort, complicated study of which to date we only have published data from the single-agent dose escalation and dose expansion cohort, which is the black box to the left. So there's also been a randomized phase 2 trial of nivolumab versus sorafenib, which has not been published. Nivolumab has also been looked at in a separate cohort of Child-Pugh B patients. So in the next few slides, I'm just going to focus on the single-agent data from the dose escalation and dose expansion study. So when the trial was started, we didn't have good data about the tolerance of nivolumab in patients with liver impairment. So dose escalation study was done, and this clearly demonstrated that patients with liver impairment up to Child-Pugh B7 could tolerate nivolumab at the full dose. And so this was then expanded to include about 50 patients from a variety of cohorts, including patients which had progressed on sorafenib or patients who were intolerant to sorafenib, and a separate cohort of hepatitis B and hepatitis C infected patients, giving a total of around 250 patients. So this just shows you the demographics from all of the cohorts that were included. So these are the outcomes from the phase 2 study. So the overall response rate was around 20% in all comers. The majority of these had partial response, although there were a small number of complete responders. In terms of disease, the maintenance of disease was around 8 to 9 months. So this is looking at the response rate across the different cohorts. So this is looking at, first of all, on the left, we've got sorafenib-naive patients, and this includes both the dose expansion and the dose escalation cohorts. And we're particularly looking at the issue of whether PD-L1 expression is a predictor of response or not. So if you look at the, first of all, the sorafenib-naive patients, you've got a response rate of 27% in PD-L1 positive patients versus 20% in PD-L1 negative patients. For the sorafenib treated patients, you've got a response rate of 22% for PD-L1 positive and 19% for PD-L1 negative. And then for the sorafenib experienced patients on the right, the response rate 29% versus 13%. So essentially, there's no clear difference between these, and PD-L1 appears not to be a good selection criteria for sensitivity to nivolumab. This is a post hoc analysis that has been presented previously, and it really reiterates what has been found across many other tumor types, that those patients that have a response to a checkpoint inhibition do extremely well and have a very well-maintained response with good survival outcomes. So here, if you look at the 20% of patients who had a partial response, then they haven't reached their median survival. And if you look at the population overall, the median overall survival is 16.7 months, and for those that had progressive disease was 8.9 months. And in the bottom of this, you can see that the 12 and 18-month survival, so for those that had a PR or CR, that 100% of those patients survived for 12 or 18 months. Those that had stable disease also did very well, so 67% survival at 12 months, 45% at 18 months, and those that progressed 14 and 26 months respectively. In terms of the toxicity, so this is looking at data from the dose expansion cohort, so we've got 214 patients here. The most common treatment-emergent drug reactions were rash, pruritus, diarrhea, decreased appetite, fatigue, nausea, and dry mouth. And interestingly, the rate of transaminitis, which was a concern in this patient population, was actually relatively low and turned out to be self-limiting. So this is looking at patients who'd had previous sorafenib exposure versus those that were sorafenib naive. So there was a much smaller population that was sorafenib naive, and also the follow-up was a little bit shorter. But you can see on the left, the sorafenib naive patients had a median survival of around 28 months, which looks very promising, although one has to be a little bit cautious because the follow-up is quite short, 73% at 12 months and 57% at 18 months. Looking at those patients that are sorafenib experienced, median survival was 15 months. And if you look back at all of the trials in the second-line setting, the median survival has consistently been about 8 or 9 months. So against that backdrop, a median survival of 15 months looks very encouraging. So the trial that we're waiting for now is the definitive evidence. This is the randomized first-line trial comparing nivolumab with sorafenib. This was conducted in patients with Child-Pugh disease, and there is a co-primary endpoint of time to progression and overall survival. Secondary endpoints of response rate and PFS. This was actually completed recruitment quite a while ago, and everyone has been waiting for this data, which I understand is going to be presented later this year. and this is going to be a critically important study for the community. So the rival to nivolumab is pembrolizumab, which is a very similar drug, PD-1 inhibitor, and this was initially studied in patients in a single-arm phase 2 trial in patients who'd had previous treatment with sorafenib, so slightly different from the 040 trial, which included sorafenib-naive patients. So this was just over 100 patients treated with pembrolizumab 200 milligrams every 3 weeks. The primary endpoint for this was objective response. And this is the data from that study. So the overall objective response rate was 17%, which is very similar to the data from nivolumab, which is 20%. And I think what you can see here, if you look down at the left-hand side of the slide, looking at the responders, you see the responses tend to occur quite early. So most of the responses are happening at about 8 weeks, and then some are happening in the subsequent or the second follow-up scan. And what's remarkable here is that the majority of patients who respond do not relapse. So the green dots are the ones that have relapsed. So you can see that out of these patients, only 3 of them relapsed, and the majority have ongoing response at the end of or at least at the end of this follow-up period. The survival also looks fairly encouraging from the Kaplan-Meier curve on the right, but obviously follow-up is short. In terms of toxicity, very, very similar to the that was seen with the 040 trial, so fatigue, pruritus, diarrhea, rash, nausea, again coming out on top, slightly lower incidence of transaminitis. But I think what's notable is that the rate of grade 3 or 4 toxicities is extremely low. So generally, this is well tolerated, but in a minority, there are serious adverse effects which need to be very promptly and carefully managed. So this is the first randomized trial of checkpoint inhibition in patients with HCC. This was the Keynote 240 trial. So it randomly allocated patients between pembrolizumab plus best supportive care versus placebo and best supportive care. Patient population was fairly standard, so BCLC-B that could not be treated with local regional therapy, Child-Pugh A. They had to be on treatment for hepatitis B and no prior to systemic therapy other than sorafenib. Now, this trial also had a co-primary endpoint, which appears to be an emerging trend. So the statistical analysis plan was split between PFS and overall survival, with the other endpoints being response rate, disease control rate, TTP, and overall response. So 413 patients randomized on a 2-to-1 basis and a follow-up of 13.8 months. The overall survival had a hazard ratio of 0.78, p-value of 0.238, PFS 0.78 with a p-value of 0.209, which looks relatively encouraging. However, this failed to meet the threshold, the predetermined statistical threshold. So this was actually a negative trial, and I'm sure there'll be a lot of debate about whether this means that approval for pembrolizumab should be withdrawn on the basis of a negative trial, or whether it should continue on the basis that the hazard ratios still look reasonably acceptable. So there's also a number of other PD-1 inhibitors that are slightly further behind. So this is camrelizumab, which has been tested in an initial randomized trial looking at 2 different doses. And the response rates here were, again, fairly similar to what has been seen with nivolumab and pembrolizumab. So this has been taken forward in a combination with chemotherapy with FOLFOX and GEMOX in both hepatocellular carcinoma and biliary tract cancer. So yet another PD-1 inhibitor, which is going through phase 3 trials, is tislelizumab. This randomly allocated patients between tislelizumab and sorafenib on a 1-to-1 basis, and we'll look at overall survival as the primary endpoint. So this trial will probably finish recruitment towards the end of this year, so we don't expect this to read out until probably the end of next year at the earliest. So there's, as with other tumor types, there's been interest in combining CTLA-4 inhibition with PD-1 or PD-L1 inhibitors, and I'm just going to briefly review some of those studies. So first of all, as I mentioned right at the beginning, the Checkmate 040 also included a cohort in which nivolumab was combined with ipilimumab. So the 148 patients randomized. The majority had either vascular invasion or extrahepatic spread. The majority were BCLCC, and 84% had discontinued due to sorafenib due to progression, and 14% due to toxicity. There were 3 different dose schedules examined, and so this is just a summary of the data. If you look at the median overall survival, which is highlighted for the nivolumab 1 milligram per kilogram plus ipilimumab 3 milligrams per kilogram every 3 weeks, median overall survival is 23 months, and then you can see for the other schedules is slightly different, but this is a small study. I think the important is that the response rate was fairly high. So across all of these schedules, response rate was 31%, which is consistently higher than that seen with single-agent PD-1 inhibition. However, 37% of patients had grade 3 or 4 pruritus and rash, and this clearly does have an impact on patients' quality of life. We've also coming to the end of the Himalaya trial, which was informed by this initial study looking at the combination of durvalumab and tremelimumab. So this is again CTLA-4 PD-1 inhibitor study. This was the initial small phase 2 trial, which has already been presented at a previous ASCO. You can see here the response rates across a variety of uninfected hepatitis B, hepatitis C patients. So confirmed response rate of 30% in the 20 uninfected patients, although for some reason response rates are rather low in HPV and HCV patients, but that obviously may be due to the very small numbers included. So looking at the side effects, again adding 2 drugs together does give more toxicity, and if you run down the grade 3 or 4 toxicities, one's getting more than one had with single-agent PD-1 inhibitors. So as I said, that initial study informed the Himalaya trial, which is randomizing patients between durvalumab, 2 different combinations or 2 different regimens combining durvalumab and tremelimumab and sorafenib. So this is a very large a trial with 4 arms, and that has almost finished recruitment. And as I say, we'll get the results of that at some point next year. So managing immune-related, I think many of you who use immunotherapy will be very familiar with the panoply of possible immune-related toxicities. So these can really affect any organ in the body, and one has to be very aware of these. The patients have to be informed, the nurses, and clearly the physicians looking after these patients. And the key point here is vigilance and speed in terms of detecting these and treating them appropriately. The management algorithms are generally defined for each toxicity, but in broad terms, for grade 1 toxicity, one can continue with immunotherapy and just add symptomatic therapy. For grade 2 toxicities, the recommendation is to withhold immunotherapy and to commence corticosteroids if symptoms do not resolve. And for grade 3 or 4 toxicities, immunotherapy should be discontinued. Patients may require hospitalization. They need to be started on high-dose corticosteroids. And it's very important not to stop these quickly. These need to be tapered very gradually over the course of many weeks, and often require re-escalation if the toxicity returns. Some patients will turn out to be resistant to steroids alone, and will require the addition of other immunosuppressants, such as infliximab or mycophenolate. So I think what I've shown you is that anti-PD-1 or PD-L1 therapy shows favorable activity and tolerable safety. I think the real challenges are biomarker development. We've shown that PD-L1 is not a good biomarker for selection of patients, and we urgently need to understand which of the 20% are going to respond to this treatment so that we don't get negative phase 3 trials in the future. I'm just going to finish off with a case which I think is an interesting case because it does raise or illustrate some of the differences which are beginning to emerge between immunotherapy and TKIs. So this was a 65-year-old man who had stage 4 hemochromatosis with cirrhosis, diabetes, but was very, very fit. He was already on a screening program and was noted to have slightly elevated AFP at 12. He had an ultrasound as part of a screening program which showed an ill-defined 3-centimeter abnormality. Went on to have cross-sectional imaging which showed the tumor that you can see on this on the arterial scan with some portal venous involvement, and he was started on Sorafenib in January 2015. 6 months later, he's had an MRI scan which shows that the tumor has progressed, and more importantly, he's also got a very extensive tumor thrombus affecting his right and left portal vein. So he tolerated Sorafenib for 6 months, but clearly didn't benefit him. So in June 2015, we were faced with this situation and had to consider what options were available to him. So we have second-line systemic treatment or clinical trials. In terms of the options, as you've heard before, we had Regorafenib, Cabozantinib, Ramucirumab have all been gone through randomized phase 3 trials. There's promising data with Nivolumab and Pembrolizumab. Actually, this patient being back in 2015, we didn't have access to all of these agents, and he was recruited onto the 040 trial and received Nivolumab. So this is June 2015. So he was treated on that. 4 months later, he'd had a spectacular response with a very dramatic reduction in his tumor, recanalization of his portal vein. So that was October 2015. If we then fast forward to March 2018, so he's now been on Nivolumab for almost 3 years with very, very good quality of life, almost no toxicity. He saw his daughter get married, have his first grandchild, so this was a major impact on his life. But unfortunately, he then progressed, but interestingly, in a different site in the liver. So you'll note that the original tumor, the original involvement of the portal vein has remained in remission, but he now has this new area of hypervascularity. So at this point, I had to see whether he could continue, but unfortunately, because he'd progressed, according to the protocol, he had to come off study. So he came off study. Now, generally speaking, with TKIs, if patients respond, then they generally will relapse in the same areas, and we tend to treat them with subsequent lines of systemic therapy. With this patient, he'd had an outstanding response, which had remained in remission, and he had localized disease. His portal vein had been recanalized, so he was now eligible for local regional therapy with embolization. And so for the last year, he's been treated with 3 embolizations, which have largely controlled his disease. And the reason I wanted to show this case was because I think it does illustrate that the new drugs that we have available are forcing us to kind of change our approach to how we manage patients with liver cancer. We're very used to patients progressing on the BCLC algorithm from left to right, but now we're beginning to see patients who have this type of response where we need to think a bit more imaginatively and consider going the other way along the Barcelona algorithm. And I think it's going to be very interesting to see how this unfolds in the future and how we change the way that we manage patients.
Thank you very much, Tim. This is really quite exciting, and it's incredible how the immunotherapy field is evolving quickly across the board, but specifically now we see the advent of that many clinical trials in regard to HCC specific. Let's try to complete the story, and I have to say that nobody would have done any better job than talk about thoughts of innovative approaches for HCC using targeted therapy and immunotherapy. In other words, let's combine them together, and I'm really very pleased to introduce and welcome Dr. Ruth Hay from Georgetown University in Washington, D.C., who will speak to us on that subject. Please, Ruth.
Thanks for the kind introduction, and organizer for inviting me to give the talk, and thanks for you coming here after the whole day meeting to stay towards the end to listen to the talk. So as you have seen the data presented by Dr. Miles, at least there's a selected group of patients who benefit from immune checkpoint inhibitors. So the question is, so in the patients who respond to IO therapy, those patients tend to have prolonged survival. Although the survival benefit of IO therapy still need to be proven by randomized phase 3 study. So looking at the data presented, the question is, how can we expand the benefit? For example, in patients with less adequate liver function, Child-Pugh class status, and are they going to have gain benefit from immunotherapy? And also, can we increase the response rate, increase the amount of patients benefit from IO therapy? Or can we move this IO therapy to an early stage of disease and really trying to cure more patients? And in those patients still have some curative treatment options. So in my talk, I'm going to first talk a little bit of data on IO therapy in Child-Pugh patient, and then I'm going to sort of provide some data to you on combination of anti-angiogenesis inhibitors in combination with IO therapy, then some data in combination with local regional therapy. A lot of my talk will be on study design because a lot of those we don't have any data yet. So as we know, Child-Pugh liver dysfunction is really associated with worse prognosis compared to patients with Child-Pugh liver function. Historically, patients with Child-Pugh liver function, Sorafenib, like the overall survival in those patients with Sorafenib treatment is about 4 months. And almost all randomized study exclude patients with Child-Pugh liver function. They all need to have Child-Pugh liver function. So there's a lack of randomized phase 3 data evaluating therapeutic agents in Child-Pugh patient. So there's a little bit of data on IO therapy in Child-Pugh patients. So there is a cohort 5 in Checkmate 040, and that enrolled patient with Child-Pugh 7 and 8 liver function. And about 50 patients' data was presented at this year's ASCO GI. And so patients with B7, B8 liver function are enrolled, received a flat dose of nivolumab 240 every 2 weeks until disease progression or unacceptable toxicities. So data from the same study, cohort 1 and 2, in which most patients with Child-Pugh liver function are presented for comparison. So the primary endpoint is overall response rate by investigator assessment. So here I want to show you one data slide showing you that the investigator objective response rate was 10.2% with a disease control rate of 51%. And so the rate of onset of response is 2.7 months. It's very comparable with the Child-Pugh cohorts. And if you look at the duration of response, it's 9.9 months compared to the Child-Pugh patient. And so the data is still early to look at survival. And if you look at the NCCN guideline does recommend nivolumab as a second-line treatment for Child-Pugh and B7. So rationale behind combination approach So actually, over many years, there's preclinical evidence to show VEGF plays a role in immune environment by affecting the dendritic cell maturation. There's quite many roles VEGF plays in the immune evasion. So which provide rationale to support anti-VEGF therapy in combination with IO therapy. And actually the combination of bevacizumab, which is a monoclonal antibody to VEGF, with PD-1 have been evaluated in multiple disease type, renal cell and small cell lung cancer. So we are involved in the initial phase 1 study combining bevacizumab plus atezo. It's a phase 1 study with 3 arms, and one of the arms is HCC, which sort of take off. It has showed some very early promising results. And so last year at ESMO, 73 patient efficacy data was presented. And here, this is the data. And of course, this phase 1 has finished enrollment. So in this data presented, you can see there is a quite promising 32% response rate. And you can see this response in the waterfall curve, and the response is seen in all subgroup of patients. And the disease control rate was 77%. If you look at the spider's plot on the right side, you can see a lot of the responders in green have quite a deeper response and also long-lasting. The median progression-free survival was 14.9 months. And then if you look at the safety, because bevacizumab is quite selective anti-angiogenesis inhibitor, so when it's combined with atezolizumab, the immune-mediated toxicity is quite comparable to atezo arm. And if you look at the percentage of patients require steroid for immune-mediated toxicities, the number is very low. And if you look at more common grade 3/4 treatment-related AEs, it's hypertension, which is 10%, which can be managed. And the common side effects, decreased appetite, fatigue, rash, and pyrexia. I think those are actually commonly observed AEs in HCC trials. So based on those promising early data and a phase 3 study has been designed called IMbrave150. It's designed to compare the combination of bevacizumab plus atezolizumab versus sorafenib, which has been the standard of care for, or like when the study was designed, that was the only frontline treatment. This study enrolled quite quickly. Actually, it's fully accrued at the end of 2018. So now the patients are being continued treatment and being followed on the study. And so now I've showed you a combination of IO plus a very selective anti-angiogenesis inhibitor. What about less selective multi-kinase inhibitor? And that have been, now we actually have four have been FDA approved for the treatment of HCC. And you can see for multi-kinase inhibitor, the TKIs, and so on one hand, it not only inhibits angiogenesis, it also hits multiple targets. Those may have important role in the immune environment. So they all, like different TKIs may have different sub-targets that may play in role, negative or positive role in the combination. And on the other hand, you also have the toxicity profile is different compared to bevacizumab. So here I want to show you the preliminary data of the phase 1b study evaluating Lenvatinib plus Pembro. And the data was originally presented at last year's ASCO as a poster, and the updated data was presented at the AACR this year. So in this, you can see the overall response rate in the small study was 42%, which is quite promising. And And then there's, but if you look at the toxicity, it's amazing that if you look at the toxicity, there's 60% patients actually with more than grade 3 toxicities. About 16.7% of patients have to discontinue either therapy or both therapy because of treatment-related toxicities. So we're still learning how to do the combination and then to achieve this promising response. So since then, LEAP-2 study has been designed. Now it's open for enrollment, and we are also one of the sites. And so patients are randomized to Lenvatinib plus Pembro versus Lenvatinib by itself. And the study is enrolling. And another phase 3 study I want to talk about is COSMIC-321, which is also about to open for enrollment. And so Cabozantinib is another TKI that Dr. Singhal has presented in his talk that it's approved for second-line treatment of HCC. It also has very interesting targets. In addition to VEGFR inhibitor, it also inhibits MET and AXL, which are known to, in preclinical research, play a role in immune evasion, so which provide a rationale for this combination. So this study is comparing Cabozantinib plus atezolizumab versus Sorafenib as the control arm. And the study also include a third arm, which to evaluate Cabozantinib as a single agent in the frontline setting. So here is an incomplete list of study that I just want to show you. It's a very hot area, and so so the combination study, usually there is a backbone of IO, either is a PD-1 inhibitor or PD-L1 inhibitor. And on the other side, it could be multi-kinase inhibitor with the main focus on angiogenesis. Now we also have the TGF-beta receptor inhibitor and MET inhibitor that it's being tested in a combination, or angiogenesis, more selective angiogenesis inhibitor, such as Ramucirumab. We know that in earlier stage or intermediate stage, and supported by level 1 evidence, RFA and TACE are recommended and standard of care. So if you look at the tumor treated by RFA or TACE, and you do see necrosis and actually increased tumor antigen release, and also influx of inflammatory cells to the tumor, and there's an increase in the tumor-specific T cells, so which provide rationale to do the combination of IO plus local therapy. So this is the study published by Duffy et al. Is an NCI Tim Gratton's team. That what they did is they evaluate the combination of tremelimumab with ablation, with really try to focus on the looking at the tumor. So you can see in this slide, I show you that the combination has increased the influx of CD4 T cells and CD8 T cells into the tumor. Interestingly, on this lower panel here, and you only see the influx of those immune cells in the responder, not in the patients without response. So additional study have evaluate the combination of nivolumab plus a local therapy, and this is a very small study, and only with at the time of presentation, it's only in 13 patients data was presented, and you can see if you just look at the treated lesion with like TACE treated lesion, 19 out of 20 target lesions showed response. But most of those patients do progress because of the untreated lesion or new lesion. And it has shown a similar toxicity profile as single agent. Here I show you there's quite a list of study combining IO therapy with local regional therapy, and from phase 1 all the way to phase 3. So you can see a lot of this are being evaluated. So in the next couple of years, we should have more interesting data. Maybe some of the questions will be answered. So moving systemic therapy to earlier stage of disease, a lot of those experiences are generated from Sorafenib because, as we know, we have had Sorafenib as an onion therapy for 10 years before subsequent approval of other treatment. So, and during disease progression and angiogenesis and metastasis and hypoxia, all those are integrated process that involved in the tumor progression, which provide rationale for the combination. So the goal for introduction of systemic therapy to earlier stage is really try to extend the period of tumor control induced by the cytotoxic effect from intraarterial therapy, and also preserve liver function so we don't have to do as many TACE treatment, as many local therapy to the liver. And as Dr. Sengel mentioned earlier, this patient really has two problems in one person: liver decompensation from underlying liver disease and HCC. So preserve liver function is very important. So of course, when we try to combine Sorafenib with local therapy, and there are many questions we don't know. And so first is how to sequence it, when to give it. So there are different strategies have been used in different study that's designed to evaluate this question. Sequential, okay, maybe patient gets TACE or Y90 followed by Sorafenib, or patients start with Sorafenib, but when they get local regional therapy or systemic therapy gets put on hold, and then patient resumes systemic therapy, or continuously, like patient continues Sorafenib while they're getting local regional therapy. I'm going to now present a bunch of negative trial, and also I want to show you the lessons we learned. So in the ceramic trial, this is a randomized phase 2 study. So patients is a comparison of Sorafenib plus Y90 radioembolization with Sorafenib, and you can see there's no difference with addition of Y90 compared to with Sorafenib alone. And of course, the subgroup analysis showed certain subgroup have benefited from the combination. And there's and then you can see the reported toxicity. There's a little more toxicity compared to single agent. And so here in this table, I'm going to show you 5 negative trials, and 3 involved combination of TACE plus Sorafenib, and 2 with other TKI. And so basically, the combination have not shown, have not made the primary endpoint to show the improved outcome compared to TACE alone. So looking at this, so what lessons have we learned? And so there are a lot of things we actually are still not quite sure. And so timing of Sorafenib. So we know when in preclinical study, when patients are given TACE treatment, and as soon after TACE, because of the hypoxia, there's a surge of all the angiogenic factors, which sort of and that promote angiogenesis and metastasis. So when to add the Sorafenib or anti-angiogenesis inhibitor in this with local regional therapy needs to be well defined, and what dose would be the best dose in combination with TACE therapy, and duration of Sorafenib. And so a lot. So we even for in randomized study when we test TKIs in advanced stage disease, and there is always a question about what is the stopping rule, and do you want to continue treatment, or when do you call it disease progression? So it looks like from our previous experience, the prolonged Sorafenib treatment a lot of times produces a benefit in patients. And also other lessons learned is the study should, early determination of study. Last year at ESMO, the data from a tactic study was presented and tried to sort of make the study design from the lessons we learned, and it's a positive study. So this study designed somewhat differently is patients will start at 400 milligrams of Sorafenib for 2-3 weeks, and then get TACE, and then afterwards get the full dose Sorafenib. And they also have introduced the very interesting study endpoint, which is untraceable lesion. So patients with a new lesion it's not considered disease progression. It's until patient cannot have additional taste, that's the endpoint. Of course, this is a phase 2 study, and the new new study endpoint needs to be tested, and the whole study, the inclusion criteria and the treatment course needs to be tested in a prospective randomized phase 3 study. So now let's move even earlier stage of disease. So so HCC after resection, actually many patients recur, and currently there is no standard adjuvant treatment for patients after a curative resection of HCC and or ablation. So STORM trial did not fail to show the overall outcome, like improved outcome in patients post-resection or ablation. Of course, there are many issues with that study because the study eventually, a lot of patients dropped off because of toxicities. So now with IO therapy, now we actually have a couple of randomized phase 3 study evaluating immune checkpoint inhibitors in the adjuvant setting, such as Checkmate 9DX study, which evaluating nivolumab in a high-risk resected or ablated patients. And this study, I think it's enrolled, it has completed enrollment in 40% of the goal. And another study is Keynote 937. It's evaluating pembrolizumab in the adjuvant setting. So patients get randomized. It's a very large study, 950-patient study, randomized to pembrolizumab versus placebo. So the third randomized phase 3 study is the EMERALD-2 study. And so this study is a 3-arm study evaluating combination in the adjuvant setting. So there are 3 arms. So the durvalumab plus Bev, the durvalumab by itself, or placebo in this patient. So this study is about to open for enrollment. And so this is, I think, this is the first study that introduced the combination in the adjuvant setting. So this is an interesting study. It's a perioperative study, and so evaluating nivolumab or nivolumab plus EPI, so PD-1 plus CTLA-4 in the neoadjuvant setting. And the data I think was presented at the GI ASCO. It's only 8 patient data was presented, but you can see there is a very promising pathological CR rate of 37.5% in the presented patients. So this study is ongoing. Hopefully, we're going to see some interesting data coming down in the future. So there are other ongoing neoadjuvant studies, and I'm not going into the details. What's the future? I think it's just amazing for the last couple of years, the landscape of HCC treatment is shifting and right in front of our eyes. So now with some of the promising early data and then the ongoing phase 3 data, now we try to predict the future a little bit. So the combination treatment may replace the single agent treatment based on the 2 phase 1 data, phase 1 trial data. And sequence and line of therapy will be determined. Right now, how are we determining it? We use inclusion criteria. We use different, we try to figure out biomarkers like AFPs, and we try to use those to determine how patient's tolerability to determine a sequence. But I believe that the sequence of the lines of therapy will be determined. It is possible that exposure of one type of therapy may make the HCC more sensitive or resistant to another type of therapy, given the very complex effect of TKI and IOs on the microenvironment. So we'll take more time to sort this out. Use systemic therapy will be moved to earlier stage of HCC and could extend, which could extend the lifespan of patients by improving efficacy of current treatment and preserve liver function. I think that's coming, although we're waiting for those data to come out. Of course, all this therapy are super expensive and has toxicities. So a biomarker will need to be discovered to really to identify the patients who benefit from the combination therapy that could potentially have toxicities. So how I think, how I treat. So I have a few points I think it's very important in the management of HCC in the current era. So bring HCC patients to a multidisciplinary team for a comprehensive treatment plan. So you can see it's complex, and through that effort, and you identify patients for their curative options versus palliative options. And it's very important to always assess patients' prognosis by determining the extensiveness of the disease, biomarker, AFP, and liver reserve. So I want to give you example, and this assessment should be ongoing, not only at the baseline and serial, whenever there's a clinical status change that needs to be evaluated. Give me an example. If a patient now with TKI with liver toxicities, IO could have liver toxicities. If you have patients who are on combination therapy, and if there is a decline or increase in transaminase or increase in bilirubin, what happens? And so that could come from disease progression and because of centrally located tumor, or a tumor thrombus block the portal vein that result in a tumor on the perfusion, or could come from the toxicity of TKI, or could come from the IO therapy. So each time, I think we always go through this exercise and really try to figure out what's the real status of these patients in terms of disease progression or toxicities. And I think it's so important to provide supportive care to treat the underlying liver dysfunction in collaborations with GI and hepatology colleagues. And I also want to treat the varices, giving beta blocker, treat ascites and encephalopathy. I'm going to give you like 2 small examples. So all my patients, they get the EGD to evaluate advanced HCC patients to evaluate the esophageal varices. And occasionally, if there's a rapid disease progression, result in portal vein blockage because of tumor thrombus, patient actually can have a significant increase in the portal pressure and result in variceal bleeding. So whenever I see that, I send those patients back to the GI to look at the varices and to make sure they don't bleed, because I've had cases like that. And also encephalopathy. And Ramucirumab and Lenvatinib has been reported to increase slightly the rate of encephalopathy. So you can see how important you recognize the symptoms and treat early before you even start them on the systemic therapy. And also maximize the patient's exposure, because there are a lot of trials available, and you've seen like a list of trials. And also provide very good education to patients to recognize symptoms of liver failure, toxicities. I think that will really help patients to have a longer run in their treatment.
Thank you so much, Dr. This is really quite tour of force in regard to what's going on in the field. And I have to admit, you know, I've been doing this for more than 20 years, and if I'm already confused myself, I can understand why you might be confused as well. This is really kind of like a major change in regard to the whole field of therapy with HCC. I go back to the BCLC for a second, because we spoke about something which is very important that actually Ruth brought up, and I'm sure you're very attentive to it, which is kind of like this kind of BCLC-B, which is a local disease, versus BCLC-C, which is like the more advanced metastatic disease. What kind of interaction can go in between? And I say that from the example that Ruth has brought up, we can see, and maybe we were really reading in the future, there's a editorial in JCO that I wrote back in 2010 that spoke about the marriage rather than the divorce when it comes to local plus systemic therapy. And this is really what we can see that could be going on in the field in that setting. Trying to put it all together from all 3 colleagues, like really, where do we stand in regard to the therapy? And I kind of like put in a scenario of the or rather the different scenarios that could be going on. This is not an implication, this is really what we should do. This is not an implication that this is what the data shows, but rather the different scenarios, what could be ultimately a way of our approach for the therapy. And of course, the classic scenario, remember Sorafenib, we have a lot of information, understanding, and experience with. Most of you know how to use Sorafenib. And if anything, the second-line therapy, exactly as Dr. Singhal has mentioned, will be Regorafenib because of this clear connectivity between the two drugs, as very well implicated in that Sorafenib comes first, progression of disease, good tolerance. And then, of course, the question would be, should we move the checkpoint inhibitors to third line in that specific scenario? Then, of course, another scenario will come, a little bit more novel, Lenvatinib, which is, again, as we heard from Dr. Singhal, is an appropriate therapy in the first-line setting. And you can say, well, if I'm on that pathway, why don't I throw in Cabozantinib as second line and then still move checkpoint inhibitors to the third line or beyond? However, checkmate 459 we're waiting for, and what if Nivo is positive, and what should follow then? And this is really where the scenarios will differ, because you may say, okay, then if checkpoint inhibitor is going to be in the first line, let me move everything which is TKI to second line and beyond. And as such, you literally switch after Nivo, you go back to where you were, which is in the classic scenario, Sorafenib followed by Rego, or you can do the Lenvatinib followed by Cabo. And interestingly, you can say, well, I probably would consider, however, I have to be rather religious about the idea that Lenvatinib and Sorafenib are really only first-line therapies. And as such, I will accept that Nivo followed by Cabo will be the appropriate approach over here. And maybe a third line, something like a clinical trial, or we'll wait to see what other data might come up. Now, the Pembro, no doubt, was a little bit of a rather well-anticipated study that we were waiting for, that we'll see a positive study only and simply because it was Pembro against placebo. And then the press release, exactly as we heard from Dr. Meyer, came in negative. And as such, the question is, where do Pembro stand? And as such, of course, Sorafenib Rego followed by Pembro, or Lenvatinib followed by Pembro, then followed by Cabo. Now, please be careful here, because I'm suggesting something which is very important. As you can see from this delineation, interestingly, as Dr. Singhal has shown us, we know very well which TKIs are to follow each other. So we have at least the story of TKI sequencing coming bit by bit. At least we're kind of, adding more to it as we move on. However, interestingly, there's a very confusing story in regard to the checkpoint inhibitors. As you can see from the different scenarios I brought up here, could it be in first-line setting? Maybe we're waiting for the checkmate 459. Even though, as we heard from Tim, the study has been waited for 2 years. Maybe a little bit later this year we'll hear about. And the question is, in other words, do you really give the checkpoint inhibitor at the beginning? Do you give them in the middle? Or do you give them at the end? We really don't have an understanding of this. If anything, this story is evolving as we go, and I think it will really require better delineation until we really see where this might take us. So how would I think? Not really different at all from my colleagues. If anything, I would say that the nuances and the kind of suggestions in regard to TKIs are rather easy to apply. Any of us can do that. In regard to the checkpoint inhibitors, I would say that the clarity is that, yes, they do work in HCC, but the translation of that response that led to two of them being Nivolumab and Pembrolizumab to get the conditional approval by the FDA with based on phase 2 data that really showed prolonged response. Is this translating into survival or not? That's something that so far we don't have any anticipation of. Now, another important point that I would like to really end up with, because this is really going to be very critical for us. This is beautiful data that you might probably have seen before. This is like almost 20 years old data by a really well-known hepatologist who was at the NCI. He still worked partly at the NCI, but he really was of our really pioneers in regard to understanding HCC, Dr. Snorri Thorgerson. And if anything, at that time, with his group, they really delineated if the patient has a specific etiology, it appears to be that the path for developing liver cancer will be running through specific markers that will go along. And this is really, again, one question that was asked by one of your colleagues, is that, would I have to check for certain things like PD-1, PD-L1 expression, maybe RAF, as I would say here, etc. Based on this, maybe, if anything, because as we can see over here, if a patient has hepatitis C, having probably the path of EGFR followed by RAF, etc., will probably quite apply. And if you recall, in the old days, when Sorafenib data came out, we thought that maybe patients with HCV will probably fare better on Sorafenib compared to the others. On the other hand, for example, for hepatitis B, it's telomere shortening. For alcohol, probably DNA methylation. For morbid obesity and NASH, as we said, maybe EGFR and P53, etc., etc. I jokingly say here that if you do those tests, probably it will be an expensive way for you to prove what was the risk factor as we can imagine. Now, I would say that a good simile to that is not Chicago, but rather New York City. And if you've been to New York and Manhattan, the subway lines are really rather, especially in Uptown, very well delineated. If you happen to be on the east side of Manhattan, where the green line is, you have line 4, 5, and 6. Just imagine for a second, this is where hepatitis C-driven HCC is, i.e. it will go through the same path as Snorri Thorgarson wrote for us in 2002, as I mentioned. While on the other hand, if you happen to be on the west side of Manhattan, on the red line, again, the 1, 2, 3 will be, for example, let's say Hep B. And as such, there's a clear delineation between the two. And this is really how we believed all along. We wrote, all of us, about it, and we connected about it, saying that the determinants in regard to a specific etiology are driven based on a specific change in the molecular markers of the disease. Well, maybe not so. Is that suggesting to us that actually HCC is more like downtown Manhattan rather than the uptown part, where, as you can see here, I can't really even untangle for you those different subway lines because really they're connected quite a bit with each other. And what the suggestion is at the moment, this is only suggestion, we're not saying this is really the truth, but we have some very, very early data that we're working on aggressively and trying to understand better. We're actually doing a great work with, believe it or not, 26 countries. Some of you are represented here from those countries, and we're trying to analyze the genetics of the HCC based on etiology and ethnicity, because interestingly, we're finding that probably a patient who have, for example, the RAF-MEK pathway running through as a hepatitis C, believe it or not, they can halfway through the disease switch to some other pathway. And this is really what we have zero understanding of. If anything, we have some suggestions. And that's why, at this point in time, to answer the question that was asked, we don't have any good clarity in regard to which marker we should check on or what kind of delineation we have in regard to these, with the little exceptions that we had here and there in regard to, for example, the Ramucirumab. So with this said, again, I have already quite a bit of questions here, so we're going to take a few minutes to really answer most of them. And the first one will go to Dr. Meyer. So the question is, of the checkpoint inhibitors, if you were to really anticipate any of the toxicity, what you will worry most about as first?
I guess the most common toxicities are skin-related, so rash and pruritus are very common, but they're not life-threatening, so they can generally be managed, so we don't worry about those. I think the things which we really worry about are, I guess, colitis, which can be fatal, autoimmune hepatitis. So these are the things which you need to look out for and treat very quickly. I would say that those are they're pretty rare to get them to a serious degree, but they need to be picked up very quickly.
Great. So definitely something that's very apparent to us is rash, but at the same time, the subtle symptoms that are apparent here and there are important. I liked very much the slide that Dr. Meyer has shown, which really tells you actually in brief that anything that patients will tell you is a potential adverse event of checkpoint inhibitors until proven otherwise. That's really probably the right approach to consider all of that. Another question which I take back to Dr. Singhal. So Amit, you and I actually we chatted quite a bit about that, and we don't necessarily agree on this part in full, but nonetheless, the question comes in as, do you use biopsy, and do you use also cell-free DNA to understand any biomarkers or anything about diagnosis?
Yeah, so Gaston, you're right. We've talked about this several times, and we somewhat differ in terms of where we stand on this. But I think that, like I mentioned when I was presenting, I think that the lack of biopsies have really set the field back. So I think that both of us agree on that point. I think that both of us are performing biopsies in our centers, really to advance research and to advance our understanding of where, HCC and what we have to do moving forward. So in short, what I think is that biopsies should play a role in academic centers where we're trying to do research and really figure out what is the next step. I think that in clinical practice, I don't think biopsy needs to be done just to establish the diagnosis. I think that we can say with good certainty if somebody has characteristic imaging, that's sufficient for the diagnosis. But I think it plays a critical role in research moving forward. Similarly, cell-free DNA, I think that it's important in terms of biomarkers looking forward, in terms of trying to tailor, treatment choices, but it's not ready for prime time right now.
Fair. And last question I would like to ask Ruth. Ruth, you mentioned quite a bit of data on the combination of therapy between local and systemic therapy. One of the questions is, however, what about SBRT and immunotherapy? Radiation therapy plus immunotherapy. Any thoughts on that?
So radiation therapy and in combination with immunotherapy, it's a very interesting research question. I think even for other disease type, it's not fully sorted out. And there is some small amount of data and testing this, but I don't think it's even close for prime time yet. There's phase 1-2 study evaluating SBRT plus IO in HCC. But because SBRT is not commonly, it's not one of the level 1 treatment options for HCC, so it's still a research question.
No, I totally agree. If anything, however, there's quite a bit of excitement on it, and give credit for actually our colleague Laura Dawson from Toronto, from Princess Margaret, who is really doing quite a bit of work on SBRT plus Sorafenib. But on top of that, we know very well, exactly as Ruth said, that there is some early data in phase 1 setting that's really looking into SBRT plus a checkpoint inhibitor. So definitely something that we'll see more of. But again, with this said, again, great thanks for PVI peer review for their incredible effort here. A great effort for my colleagues, Dr. Singhal, Dr. Meyer, and Dr. Hay for really an input that's really very valuable. Super great, thank you.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/XEJ860. This activity is supported through independent medical education grants from Bayer Healthcare Pharmaceuticals Incorporated, Bristol Myers Squibb, Exelixis Incorporated, Genentech, and Merck & Company Incorporated. This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education.